So my name's Brad Rozecki. I work for the company that makes Urology. I've met some of the OR staff as we've done procedures here. And I'm really glad to be able to come down and provide lunch for you guys today and introduce Dr. Stormont, who is going to talk a little bit about BPH treatment overall and a little bit about Urology. On the tables in front of you, there's a couple of things. There's a patient ed brochure that kind of covers some of the information that Dr. Stormont's going to talk about. I see there's a lot of women here. You're certainly welcome to take those to any guy who's driving you crazy because he gets up at night or can't drive all the way to Madison without stopping once. Also on the table, there's some IPSS scores sheets that are a way to measure symptom scores for men, and you're welcome to take those as well. And also, last thing I'll mention too, if you didn't see the sign-in sheet, if you guys can make sure and find that before you head out, that'd be awesome. And turn over to Dr. Stormont. Thanks.
Thank you, Brad. Hi everyone, thank you all for coming. This talk is gauged towards male issues, but we all know males in here who probably suffer with this. These are very common, and really the goal of all the treatments, of really everything we do, is improve the quality of life for them and sometimes you also. The outline, we'll talk just quickly who I am, where I came from. Common urology issues, we'll go through those. Lower urinary tract symptoms is a main portion of the talk. The Urolift system, why I think it's a great option for lower urinary tract symptoms or big prostates, prostate enlargement, and then let you ask some questions. So I have no financial disclosures. Lunch is provided by Urolift, and thank you to Brad for providing the lunch.
Thank you.
So I grew up in Monroe, Wisconsin, graduated from Monroe High School. I did undergraduate and medical school at University of Wisconsin-Madison. I was a high school teacher for a little bit in between there, high school special education teacher. I did some more residency training out at University of Maryland, close to my wife's family. And now I've come back home. I'm happy to be home. And I work here and at Grant Regional Health Center. I have a wife, Emily, and then I have a daughter, Isabel, and I have to plug both of them because that's the most important thing to me is my family. So my little girl there, she's now over a year old, and then there's my son, who we have a lot of fun together, but he's kind of a monster. So. Common urologic problems, things that we deal with here, blood in the urine. Urologic cancers ranging from prostate cancer, bladder cancer, kidney cancer, kidney stones, erectile dysfunction, low testosterone, urinary incontinence, and lower urinary tract symptoms, among other things, but these are just the more common things. Causes of hematuria, that is blood in the urine, that's what that means, and there are numerous different causes. Infection is one, cancer, inflammation, drugs, kidney stones, and this needs to be evaluated. Lots of people say, oh, I saw blood in my urine once, but it went away. It still needs to be evaluated. That can mean there's something bad going in there. There should be an anatomic evaluation. So many people think once it clears up, it's okay. There's nothing there, but that's not the case. One of the causes of blood in the urine is stones. So this is a picture of a CT scan with the right kidney with a large stone. Stones can be painful. Stones can cause bad infections. They can cause blood. That's something that we treat here. We can treat all types and sizes and forms of stones. Erectile dysfunction, you hear ads during football games, during the Super Bowl. You're going to hear numerous ads probably for this. This is a huge problem, and many people are struggling with it. They're embarrassed to be seen about it, but they shouldn't be, because really half of all men in the United States age 40 and above are affected by this. Once you get over 70, the number's even higher. There are a lot of good treatments for this. We kind of go in a stepwise fashion. You start with the pills. The pills have side effects. They can be very, very expensive. There are some generics now, so I almost always start with pills and see if those work. Lots of times the pills stop being effective. Then there are injections, which work almost all the time initially. There's suppositories. There's a vacuum assist device, which we can teach you how to use. You buy that on your own, and we can teach you how to use it. That, even in people who have had terrible injuries down there, their prostates removed, etc. This works in, if you use it correctly, in about over 90% of the patients. And then sometimes you progress towards surgery, which is a penile prosthesis, which I've done hundreds of these. It's a great procedure, and I think we need to get the word out that we offer that. It's something you basically put a device in, and you can pump it up and release it whenever you're ready to go. Low testosterone is something you also see ads for this all the time. As men get older, they stop producing the testosterone they used to produce. It gives a reduced sex drive, low libido, erectile dysfunction, decreased strength, energy, weight gain, loss of muscle. All those things can be from low T. So there's a logarithm that we use to test for this. You need to have a morning testosterone draw. That's the only time it's reliable. Men's testosterone goes like this throughout the day. There's a big study done at the VA that showed that the only reliable testosterone is done in the morning. You have to have 2 that are low, and then there are great treatment options. There's people who use gels, there's people who use shots every 2 weeks. We actually have options that last 3 to 4 months that are probably better for the patient, keeps a better baseline level of testosterone. Also, they don't have to come as much for treatment. So this is kind of the meat of the talk, is the lower urinary tract symptoms. And what does that mean? That means when you have issues urinating, essentially, for men. BPH stands for benign prostatic hyperplasia. And the symptoms are incomplete emptying, or the sensation that you're not emptying your bladder, frequency running to the bathroom quite a bit, intermittency, so the stream comes and goes, and it kind of goes in a pattern like this. You'll fire a little out, and then it'll stop, fire a little out. Urgency, running to the bathroom, weak stream, spraying urine. You spray urine all over the toilet. Sometimes that might not bother the person doing it, but it definitely bothers the people coming after them. Straining, and nocturia. And nocturia is getting up a lot at night to urinate, running to the restroom. So this is usually caused in men by prostate enlargement or BPH. It's the most common benign neoplasm in men. 3/4 of men over 70 suffer with this. Most men are just on medications, and we're going to talk about that. The medications don't work very well. The compliance is poor, and medications have a lot of side effects. Medications do work well for certain patients. I do prescribe these medicines a lot. There's certain prostates and patients that respond very well to medicines. The gold standard for surgical treatment is TURP, and that stands for transurethral resection of the prostate. That is historically how it's been, and what that means, and most guys call it a roto-rooter, or you ream me out, or all these, and it is a fairly invasive procedure where you shave out prostate tissue to open up the pipe. It works very well. It's a procedure that I have done a lot of, that I still do, but it is invasive. It requires usually a night in the hospital with a big catheter in, fluid flowing in and fluid flowing out, which is continuous bladder irrigation. So that's not all that appealing to patients, and you can see there's a big jump from taking medicines to having this type of surgery. There are also a lot of side effects to this surgery that we'll talk about. So in the 1980s, there was no medicine. So people who had BPH underwent transurethral resection or a TURP, and this does have great impact. It improves people's symptoms, but you'll see for the first 6 months, there's a lot of issues with delayed bleeding, bleeds, you end up in the hospital, a catheter goes in, you have to be flushed out. So there are risks to it. There's risks of ejaculatory dysfunction that are quoted at 50 to 65%, meaning you'll ejaculate and you will not be able to see your ejaculate because there's no bladder neck. You've resected through it, and the bladder neck needs to be competent to see that. In the 1990s, this shifted from surgical treatment to medications, and since the 1990s, this has pretty much dominated. Most people are on medications, and you can see why. It's easier to take a pill, but one of the issues in the United States now is there's a polypharmacy. Everybody's on numerous pills, and these tablets, although they work okay for these symptoms, they also have a lot of side effects, and we also don't really know how they interact with other medicines that are people on for blood pressure and other things. So if you look at the BPH population, the lower urinary tract population, there's about 40 million. 22 of them have an IPSS score of greater than 7. And 7 to 10 is kind of mild, medium symptoms. And once you start getting double digits, those are pretty profound symptoms that you're having with your voiding. And then about 12 million are actively managed. Most of these are with medications. You can see 7.5 million. Very few of them undergo a procedure, and that's because of the invasiveness, right? When you tell a man that he might lose erectile dysfunction and ejaculatory function, they're not thrilled about the procedure, and I get that. Also, a lot of these men stop taking their medicine. Some are just watching their symptoms, and we'll talk about why that's not always the best thing to do. So the problem with meds is non-compliance. People prescribe these medicines all the time, including myself, and people stop taking them. There have been studies that have shown that only about a third of people keep taking them after the first year, and then that drops even lower after that. A lot of that is because of, they take numerous pills. They're trying to figure out which ones are important, the way it makes them feel. They might not even know that side effect is coming from the medicine. And lots of them don't work that well. So there's certain prostates that won't respond very well at all to these medicines. So side effects, we have a lot of well-known side effects of alpha blockers. An alpha blocker is tamsulosin or Flomax. I'm sure you've all heard of that. Rapaflo, Uroxetrol, doxazocin, all those things are alpha blockers. They all work the same. There's a little bit differences, but all of them have the potential side effects of lightheadedness, headaches, fatigue, ejaculatory dysfunction. You get anejaculation or retrograde ejaculation because the bladder neck doesn't close. Insomnia, and one that I've seen a lot lately that most people don't think is coming from this is nasal congestion. And they'll make them miserable, but they don't attribute it to that medicine, but once you get them off, it improves. Some newer side effects are intraoperative floppy iris syndrome, and what this is, it's actually now been well documented with Flomax, which is the most common medicine. When you undergo a cataract surgery, as many people have when they get older, the iris is floppy because you've been on the Flomax. Sometimes this can happen even after just one dose of it, and it makes the surgery for cataracts more challenging. So that can be an issue. That you can usually get through it, but it can make it harder and maybe not as effective. Also, they're finding that there's an possible increased risk of stroke and possible increased risk of dementia with alpha blockers. Lots of times the alpha blocker is combined with 5-ARI, which is finasteride or dutasteride. Proscar is another name for it. And this can decrease libido. Basically, it knocks out some of the hormones that are normal for a male. It can decrease libido, it can increase breast tissue, cause gynecomastia, diminish ejaculate. And then this one is big because it can lead to metabolic derangements such as metabolic syndrome, increased blood glucose, things like that. And also they found that this might increase dementia risk also. So you toss these two drugs in with the side effects, and somebody else has taken 5 to 10 other drugs for all their other health issues. We don't even really know how these drugs interact. And so the question is, what is more invasive? Procedure that is done, keeps you in the hospital overnight in a TURP, doing a procedure that's done and you leave the same day, or possibly giving you something that affects your whole body and basically is toxic to your whole body. I think that's something we don't think about. Lots of people like to take pills, but there are side effects to the entire body that we encounter. And so basically right now we've got medicines, we do nothing medicines or a TURP. And then they came out with certain other things that we'll talk about a little bit. Urethral stents, those failed miserably. They got stones on them. They would do some microwaving of the prostate. That failed. That's not done anymore. So they're trying to find an in-between, and there has not been a good in-between that has been identified. And what happens is people have a healthy bladder right here. You can see that's a bladder that squeezes well, gets the urine out, and here you progress to bladder is weakening essentially. It is not able to generate the squeeze that it once was. It's because it's overworked. It's pushing against an obstruction, pushing against the kidney tube. And then here, this is permanently damaged. That's where we start to get to an end-stage bladder. And that I see patients that come to me when they're older and they're unable to generate any squeeze in their bladder. When that happens, you need a Foley catheter, you need to catheterize yourself a few times a day, you need a suprapubic tube, because that never comes back. The bladder doesn't fix itself. So people who are continuing to have symptoms, it's kind of a warning sign. If you have chest pain, it's a warning sign that something's going on in your heart. When you have lower urinary tract symptoms, it's kind of the same thing. Something's going on in your bladder. In a man, usually it's from the prostate blocking the pipe. So if you end up in my office, most people have already tried the medicines. They're not happy with it. It's not providing the relief they want, or their side effects. So the typical workup when you come in, if you want to be evaluated for something else, is you get urine tests, you get a prostate-specific antigen, which is a PSA, you do a digital rectal exam, you look at the flow rate of the urine, and that gives us some information, and then you look into the bladder, and you also measure the prostate from behind. These are all low-risk procedures, but you need to gather this information to see if you're a candidate for what type of procedure to improve your symptoms. And this is where the UroLift system comes in. It's a good thing that has much better impact than medicines, a much lower risk profile, in my opinion, than medicines, and then also a lower risk profile than transurethral resection, with similar outcomes, at least in quality of life improvement, but you also have quicker recovery and quicker back to work. So what the UroLift system is you basically are putting some small sutures, tacks. One of the OR nurses called it a bobby pin of the prostate. And so you're basically pinning the prostate back. And when this came out, and I did my first one about 6 years ago, I actually did not think it was going to work very well. I thought what would happen is the prostate would just grow right over it. But what they found is the prostate does not do that. The results have been very good. And the reason is, they hypothesized, they've shown in dog models, is that it basically cuts off the blood supply to that portion of the prostate. It pinches the vessels, and that ultimately allows the tube to stay open. And if you look at the flow equation, increasing the radius of a pipe even a little bit improves flow a great deal. So I think that's one reason you increase the radius. You can see here, pre-procedure, both of these prostates, you're pushing against the narrowing. And your bladder's not used to do that. When you're a young boy or 20, you don't have to do that. When you get older and your prostate grows into the urethra like that, you're pushing against it, you're trying to open it up and get as much flow out. That's why you have those symptoms. The UroLift, you open this up, you can see nicely right into the bladder. You can also see that the bladder neck, which is here and here, is maintained, and that is what allows you to maintain your sexual function, your ejaculatory function. That bladder neck is not like that when you do a resection of the prostate. It's wide open. And so the TURP does help your symptoms, but it also causes all the sexual side effects and sexual dysfunction. So this is just a picture of kind of what happens. Usually you put in 4 implants, 2 on each side. Sometimes 6 is required, sometimes 2 is required. And you can see it's a quick procedure, same day. Usually you leave the hospital that day without a catheter in place. That's not true with a TURP. You always have a catheter in place. So the goal is to mechanically open it. Here is another good picture. The urethra is pinched, and then you open it up. You take pre and post pictures to make sure you're open. One reason it's so safe is because the main areas of bleeding are the dorsal venous complex on the prostate. This is a prostate right here. And then you have the neurovascular bundles. You have those on each side. Those are very important in the erection, for erections, for blood flow. And what happens with a TURP, sometimes these can be damaged, specifically down in this area. If that happens, you can get erectile dysfunction. The UroLift is usually shot, it's got a wide area in between these, and that's why the risks are so much lower of any, and basically there's no sexual side effects to doing this. There is 5-year data out now in the LIFT study that showed great results. And so I told you I did my first one about 6 years ago, and I was skeptical. This is the 5-year data, which is great, and then the 7-year data is going to be published, and it shows the same thing. The symptom severity score drops substantially, the quality of life improves substantially, and then your flow rate improves. And if you look at the other options, it's pretty similar to TURP, and the retreatment rate is similar to TURP, a little bit less, or a little bit more than TURP, but it doesn't have the risk profile that shaving out the prostate does. One thing, they've done more studies now that haven't gone out quite as far. They've been out about 2, 3, 4 years now, but it's reproducible results. It's probably not as technically challenging as a procedure to shaving out the prostate or using the laser. It's something that people, different surgeons in different places can learn how to do and do it effectively. You can see that these lines are all pretty much similar, showing similar results. So the Urolift does not have the same improvement in symptoms. It's a little bit less. It also has a little bit lower flow rate improvement. But the biggest thing, which I said the goal is quality of life improvement, the quality of life is very similar between resecting the prostate and putting in the Urolift. And I think part of that is because the recovery is so much longer for the TURP, but then also the side effects of not seeing your ejaculate, possible erectile dysfunction, things like that. So the goal is to improve quality of life, and these are similar, and doing it in a non-invasive way with lower risks is a great thing. I think also appeals to many men. Here it kind of talks about the minimally invasive profile. You have dysuria, which is burning when you urinate in blood. That lasts usually 2 to 4 weeks, and then it improves. Usually by 1 month, men are very satisfied with this procedure, and you can see they're much happier with this procedure at 1 month than they are after a resection of the prostate. I've talked a little bit about the sexual side effects, and you can see here that the only one that has no sexual side effects is the Urolift. No erectile dysfunction, no ejaculatory dysfunction. So of the minimally invasive techniques, these aren't even done anymore. And people are starting to use steam, but there's not very much good data on that, and it's called Resume. It's out. It's a newer procedure, but we don't know how long it lasts and what the long-term effects are for that. So that's something that I'm going to keep watching. But you want to see how long it lasts, because the life expectancy after you do this, you want a procedure that's going to go with them there, hopefully, until they pass, right? They don't want to be retreated, and we don't really know how steam works for that. One thing that I really like is a return to work, that people go back to work on average after 3 days. So you do the procedure on a Thursday here, and they're back at work on Monday. So there's not much time off work. I think that's probably the most impressive thing from the study. And then no missed work at 1 month, and that's not true with TURP. People are still missing work. Sometimes they still have a catheter in. They have to have a catheter in. They've had some ED visits. So here it just shows the recovery. And so ultimately, after about 6 months to a year, the recovery from transurethral resection of the prostate and Urolift is similar. But for that first 6 months, you can see that people are much more satisfied quicker after a Urolift procedure. So that's why if you're a candidate, if your gland is the right appropriate type of prostate, I do usually recommend this. This is a slide that I really like. It shows the different rates of symptom improvement, quality of life, and then the risks associated with getting those. So you can see Urolift, the results of symptom improvement and quality of life isn't as great as shaving out the prostate, but it also doesn't have all of these risks, including the need for a blood transfusion. And then if you look at medicines, the medicines are caked with different side effects, and that can range from mild to severe, and sometimes you combine these and you have a little bit of each. And also what we found is that the Urolift is much more effective in improving symptoms and quality of life without pumping yourself full of 2 to 3 additional pills a day. So where does Urolift fit? Like I said, by the time I see men, usually they have failed Flomax or finasteride, or they've had symptoms, side effects that they can't deal with. And so if that's the case, then you do go through an evaluation to see if you're a candidate for Urolift or a candidate for TURP. Some people that come to me on their own and haven't tried anything. Usually then I will try an alpha blocker and see if it improves, see if they have side effects. Some people are unwilling to take any more meds. I already take 10 meds, I don't want to take another one. And so that's a discussion. So usually I lay out all the options of what to do. Before you're a candidate for a Urolift, you do need an evaluation. You need to look into the bladder. You need to prove that it is the prostate that's blocking down. If you look in the bladder and it's wide open, it's probably not the fact that you need to open the tube. So that needs to be proved. You also need to measure the prostate and see how big it is. So it is a great option for the right patient or right prostate. These are things I hear from many men. Most men over the age of 50 have something like this, and they don't like to talk about it. They're embarrassed by it. They don't want to come see anybody, but there are things that we can do to help you. So it's a great option for men who are frustrated by the side effects or the fact they're taking medicines. They've only had modest symptom improvement. Like it showed that sometimes the symptom score improved 4 to 5 with taking those medicines. Is it worth it to take a pill every day when you only have mild improvement People who don't want surgery, who said, I don't want a roto-rooter. I heard my buddy told me that was terrible. He bled for weeks. And then people who want to preserve their sexual function. Those are all people who are candidates for this procedure. And that is the end. I'll open up to any questions that we have.
Post-Urolift, if patients were on medications prior to the procedure, do they typically have to be on those medications after the procedure?
Usually they get off. That's the goal. A little bit depends on when to take those off, how severe their symptoms were before. Some men, we kind of talked about the end-stage bladder. Once you get there, your bladder doesn't recover immediately because it's been working so hard for so long. It takes a while for some of the urgency issues, some of the overactive symptoms to improve. So you may or may not keep them on for a while, but the goal is to get people off those. Like I said, there's those side effects of dementia are ones that have been newly found, and if you take numerous meds that might increase the risk of dementia, I mean, where does that leave you? We don't know. And so that is something that worries me, and I think we don't really know how they interact with all the other meds people are on. So I ultimately try and get them off, and usually they're happy with just the procedure. Yep.
With this Urolift procedure, where you pinch off part of the bladder, I'm assuming that lowers the volume that the bladder will hold in?
Nope. You're only pinching off the prostate. You're in the urethra, so so the bladder is not touched. So if you see here, this is the bladder right here. Here's the bladder neck. So the implants go into the prostatic urethra. So basically what you're doing is you're reopening the tube. So it doesn't do anything with bladder capacity. Also, a question people ask is, well, when you do this, can't you get stones on this? And what happens, this is so small that the mucosa, the urothelial mucosa, grows over it and protects it from any stones. We haven't seen any stones on Urolift implants that are placed in the urethra.
So are the little clips metal, and then does that preclude them from getting an MRI in the future?
It does not preclude them from getting an MRI. There is some metal on there, but there's no issue with MRIs. It's only a small amount.
What's the infection risk?
There is always an infection risk. The infection risk isn't from the implants, it's from the procedure itself mostly. So whenever you have a scope put into your bladder and your urethra, there's a risk of infection. It's only about 3% in the studies. The LIFT study showed about 3%. And a lot depends on preoperatively, I get a urine culture before to ensure that it was negative, but even with that, if you're not emptying your bladder very well, your risk of getting that infection is higher.
Is there a risk for dislodgement of the clips?
I think that's there. You can have misfiring of the clips, and then if that happens, you got to get them out. That's a very low risk if you're putting them in the right spot. Sometimes with the bigger prostates, there is a little bit. It's a little more challenging you're trying to open it up, and you can kind of misfire them. But generally, nothing needs to be done if they are misfired or dislodged. Usually, what will happen is that it'll just grow over, and they're fine. Yep.
So how long does this procedure take?
It takes usually, the part that we're working is usually 15 to 20 minutes. It's a short amount of time. You get a little anesthesia to make you comfortable. Then you wake up. Sometimes you wake up with a catheter in that we remove. Sometimes you go home with a catheter for a night if there's a little bit of bleeding. But you go home pretty much the same day, pretty much all the time. Some people end up staying if there's any issues or concerns. Sometimes there's anesthesia concerns, but usually from this procedure, you end up going home. If you have the procedure in the morning, you're home at noontime.
So you do it in the OR,
We do it in the OR, yeah.
not the office, because in the book it says either way.
Yeah, so you can do it. What we do is we make patients comfortable in the OR. Our office isn't really set up to do that. But yeah, you give them a little sedation, so they're usually not going under complete anesthesia. And then, it's quick. You put a few implants in, and then they wake up.
What ages is it approved for?
So it's approved for 40 and above.
45.
45 and above.
Yep.
So yeah, and I think that they've also approved it for the median lobe, and so this is lateral lobe encroachment. And the median lobe, sometimes you can see that in here. It is FDA approved for the median lobe, but the studies haven't gone out real far regarding that, so I'm not putting them in the median lobe yet. I don't think that's the best treatment for it. I think probably shaving out the median lobe, but we'll see what that results show from the initial study of doing those.
Getting into the cost, does Medicare pay for it, insurance companies, so they pick that up, or?
They do, Medicare pays for it, yeah, I think they pay up to 7 implants is,
Do you have to have a trial of medication prior to? For Medicare?
not always. Some insurance companies, it depends, want you to try 2 medicines, but that's insane because the medicines work the same, the mechanism of action is the same. And so, if you just write, say, look, he's unwilling to try he failed this medicine, he's unwilling to try again, he's had side effects. And also, if you think a lot of the people that I'm seeing are older, they're on blood pressure medicine. One of the main side effects of the alpha blockers is lightheadedness and dizziness. If you stand up and fall, and break a hip, break a pelvis, that's huge, right? That's a huge issue for an elderly person. So that side effect in and of itself will get you out of having to try anymore. You just say, oh, you got lightheaded, and he doesn't want to try it again. And it's not worth the risk of trying another one that's going to have the same effect. Yeah.
What if they have a lot of coronary artery problems, heart disease and stuff?
Yeah, it's still fine to do. The issue is you do need to be off your aspirin or Plavix or warfarin until your blood for about a week. And so, because bleeding is a risk, you are still putting a hole into the prostate, and so they need to be healthy enough to be able to be off that for a week.
Can you bridge them with Lovenox if they?
You can. Yep. And you just stop it the night before then.
And if they're on some of the new oral anticoagulants, the same, like 48 hours prior?
So, what is it, for Xarelto, is it a 3-day hold? And that's, yeah. So, any other questions about anything? Doesn't have to be Urolift related. Blood in the urine, kidney stones, erectile dysfunction. Probably don't have a crowd here to ask those questions. All right, well, thank you very much for coming. I'll be here if anybody wants to come.